Good afternoon or good morning, everyone, and welcome to today's expert webinar for the 2018 Learning Collaborative. Today's webinar is focused on snapshots from 3 2018 MQii Learning Collaborative members. We are very excited to have 3 of our different Learning Collaborative sites joining us today to share their experiences implementing some different quality improvement projects focused on malnutrition, quality of care, and providing some insights and guidance to those of you who are trying to do similar projects and could potentially learn from their experiences. Before we get started, I just wanted to make one quick housekeeping note. All of your lines have been muted upon entry to the webinar, so should you have any technical issues, please use the chat function to let us know if you have any questions or need assistance. You can see it. Depending on your WebEx platform, it'll either be in the upper right-hand corner or some of the newer WebEx platforms have it in the bottom of the screen. You'll see a little quotation bubble that you can use to chat with us. You can also use the Q&A function to send us any questions that you have. So for today's webinar, we'll have 3 of our sites speaking to the work that they've done. First, Barbara Sherwood from Intermountain will be talking to strategies in data collection and analysis for a multi-facility organization. Next, we'll have Louise Merriman and Kristen Matheson from New York Presbyterian speaking to prevalence monitoring, nutrition screening, and outcomes. And then finally, we'll have Lori Hartz and Cheryl Shockey from Theta Care speaking to nutrition risk screening and identification of patients with malnutrition. If you have any questions for any of the speakers, again, please do use the chat function or the question and answer function. Your lines have been muted, so you won't be able to verbally ask those questions, but please send them to us via the chat function. We will collect all those questions, and then at the end, during the question and answer session, we will be able to pose them to our speakers and have them respond to your questions. So without further ado, I'm going to hand this over to Barbara to speak to strategies in data collection and analysis for a multi-facility organization.
Great, thank you so much. So I'm Barbara Sherwood. I'm the Clinical Nutrition Manager for over 4 facilities for Intermountain Healthcare. I reside in the Salt Lake City Valley, and I have the largest medical center within Intermountain Healthcare, as well as 3 other facilities, 2 community facilities and 1 moderate-sized hospital. And I'd like to talk about kind of the journey of getting started and you know, just kind of strategies of pulling it all together and how to do it. So the biggest part is building your team. So when the MQii was presented to me, I mean, it is kind of a big ask, and you know, where do you go? And you really have to, you know, build your team and making sure that you identify leaders in other departments that can help you, and find your engaged staff members. You'll need to continually evaluate the data. Once you get it back, when you think you're done, you're like, oh, wait, this doesn't really add up. And so kind of looking through that. And then use the data to find your CI pathway, where you're going to go with that. And having your team, whether it's other managers or your own team that you manage, having them help you with the direction. So those are the 3 points that we'll go over today. So on the next slide, you know, building your team. That's really important. So I'm involved with the Utah Academy of Nutrition and Dietetics, along with some other Intermountain Healthcare employees. And one of my biggest advocates was Kurt Calder, who's traditionally a dietitian on the Utah Academy board, but he also works in our IT department. So he was a key player that introduced me to other people within IT and how to get a data architect, basically, somebody who builds the platform of the information that you need. So you know, so knowing key players outside your designation is important. You know, nursing as well, knowing key players there. And then asking questions, how are people getting their projects completed? So I worked in an office with a gentleman that was over the respiratory therapy physicians and working with them, and he was a key component of, you know, different people that I could reach out to and ask questions. Now, how did you get that done? And I found a lot of information by asking questions of other people who work on projects in leadership positions on how did you get your stuff done. And they can give you some good direction and find out people that can help you. What leaders are being held accountable to accomplish is another one. Intermountain Healthcare just went through a complete restructure of our organization. And we're really kind of focusing in, instead of leaders having, 12 different goals, just having, key goals, 3 different goals in which they can accomplish during the year. So knowing what your boss is being held accountable to, or your leadership or your board of directors, is very important. So that way you can maneuver your project to line up with their goals, and you will gain a lot more support. So when you're speaking their language and know what's important to them as you're presenting your projects and how they line up with their goals, will get you further. If your direction or your project doesn't really quite relate to what they're doing, they're going to be less likely to help you out or give you more support. So, and research. We have an IRB department here. I don't know if other facilities, if you have an IRB department, but that process can be very time-consuming and complicated. It took about 6 months to get our IRB approval for our MQii, and our final submission, we finally got the IRB representative on the phone to walk us through each question, and we thought we were so crystal clear with our intentions and what we were explaining, but they speak such a different language, they're not clinicians, that we're like, oh, we had no idea you thought of it that way. So that was really kind of an eye-opener. And then your staff, making sure that your staff are engaged, what's important to them, and keeping it in top of their mind what the direction of the organization. So, and what you want to accomplish may not be feasible the way that you see it going. So having conversations with your staff can really enlighten you to how things are done on the units, or how they may have evolved since perhaps you were doing frontline care, is really important. And then setting timelines. I have found in this project, a lot of my timelines have been derailed just in the nature of a restructure. But if you have timelines set, even if they're something that you've made up, it really helps the project get moving. So I need this by this date. And sometimes, it won't happen, but at least people know that there is a timeline in which they need to set their goals, in which, for things to be accomplished. So on the next slide, the engaging your staff. So we have a live meeting, which at the medical center, I have dietitians. I have about 9 staff members on staff each day, but we're located in all areas of the hospital, which is about a half-mile long. So it's not easy for us to get together every day in the same spot, but one day a week, we have a huddle board in one of our offices where we post where we are on projects and where we need to go and where we are on our goals. And that's a really good way to keep everybody informed, involved, and thinking, on the project. So that's been a key point of being able to identify barriers. Like, well, okay, why aren't we getting past this point? And staff really engage. And you really identify your leaders on your team. There are a lot of people who want to help out, who want that leadership development, and so they're great team players, and they're good people to have on your staff to advocate. So I found a few of my new dietitians who are really interested in it have really evolved and shown up to be key players on it. On the next slide, the data building. So I identified my IT person who's been amazing, and his name is Kyle Bell. But Kyle and I speak different languages. So the pictures that you see here kind of, represent what Kyle sees on the left and what me and my staff see on the right. So for him to understand what I'm talking about, or me to understand what he's talking about, is a big leap. So we set up every other week we meet and we kind of discuss where are we on the project. And we've had to, really come through some barriers in communication of what he thinks I'm saying and what we enter on the front end. So what we do is I have walked through, walk through my screen, like this is where I enter the data, and this is how it populates on our notes, and this is what, physicians see, or this is what the coders see, which helps him develop the code on the left to meet our expectations. So, and then acronyms. Be really careful of using acronyms with people in different departments. Like DME, diabetes education, or the durable medical equipment. Little things like that. That's just one example. But those are things to get away from when you're working with other departments. We found that we had a couple things that were completely off base just because of using acronyms. So that's another thing. And then also the different programs. Cerner is a very customized program, and we've almost over-customized it to where it's been very difficult to pull the information. So that was also something else to consider. So Kyle and Intermountain Healthcare have offered to help with the next Cerner. I don't know if any of you on the line are Cerner clients, but we are happy to help, guide through that process with Cerner, because it was, I think Angel can attest if he's on the line, that was a very eye-opening experience of how difficult it is to pull data because of the customization that we've done through the couple of years that we went live with it. So the next slide, data building. So meet with your staff to walk through the data. So we thought we were pulling things that were representative of what we're doing. And so walking through it with your staff and with your colleagues. Things that you just don't know until you find out. And an example of that were our care plans. So we could create a care plan, but nursing or a physician could actually complete it or delete it. So we had to customize our data pool to show if a care plan had been created at all, to represent that we were making care plans. And so that was a catch that we didn't realize it was happening until we got our data back, and it showed that we had, 2 people with a care plan for, a 500-bed medical center. It was like, wait, this is not correct. What is going on here? So looking at the data and then walking through it to find out why numbers would be different, and so that was pretty eye-opening as well. So those meetings are really important. So on the next slide, evaluating your data. So I have a little screenshot of when we first got our data at one of the facilities. So this is just question number 1. So your measured population is 368, with malnutrition 26, and with a care plan 21, and so the numbers weren't representative of what the literature represents. So if we have 1 in 3 patients that either are or become malnourished while they are in a hospital, that number should be a little bit higher. So going back through, meeting with your teams, discuss, how is the information being entered on our side, walking through with IT, making sure the data is built to pull the way that we need it to, and then discuss, different ways that we want to see the information. And really looking at the ends. What does the literature support? And then, how is your data pulling? So, when you first think you're getting your data back, it's like, yay, and then you get it back, you're like, wait, this doesn't quite line up. So, but that's kind of the fun part about it is, keeping progress going. So on the next slide, the, pulling up your own dashboard. So the data that you get from Avalier, I have gone in and kind of simplified it because my leadership wants to see it, and pulling it in a way that, just shows where our progress is and making sure that we're making progress. And this is also very interesting when you look at the data, how differently, because data is all being pulled the same, but each of these facilities has very different numbers. And so just in that fact, we realize how differently each of our caregivers or facilities are doing things, even though we think that we're really standardized. And It may take several submissions to get really good data, but don't be frustrated. You just kind of massage it and work with it. But just making sure that you can explain it to your leadership where you are and how the numbers are progressing. So, on the next slide, the regular meetings, be prepared for delays. My IT architect, his wife had a baby and he went on paternity leave, so things like that happen. Data discrepancies, just figuring out, how did we write the code and is that really the accurate way to pull it? And then other projects. As I said, Intermountain has gone through a major restructure and some departments have gone through several. Your project may be on the back burner for other people in other departments. So don't get frustrated, just keep on task, but keep your leadership involved and informed so they understand where you are on your projects. And then with our leadership, Mark Harrison, he took over Intermountain Healthcare as our CEO about 2-3 years ago. And when he came on board 2.5 years ago, nothing really changed for about a year. And then the second year, there was a lot of changes, and they keep coming. And one of the things that he said is, if you think you're done, then you're done. And so with healthcare, just knowing that the culture of continuous improvement is always going to continue, to keep viable and also keep our patients safe and, doing better in healthcare. So let's see on the next slide. Where do you go with the information? Always keeping your team involved in part of the decision of your CI project. Keeping your staff engaged. An important part is supporting them with continuous education that is in the culture of CI. That's one thing that I think keeps them motivated, is sharing in those and providing those CEUs that are supportive of finding continuous improvement projects as in relation to nutrition or malnutrition, so they understand the importance. So out of sight, out of mind is one of the things, but always keeping your staff engaged and informed and up on what is currently being offered for continuous improvement, and then CEUs. Always continue to evaluate your data, keeping on track. That's one thing the dietitians, there's things that can fall on the back burner, but you want to make sure to keep the malnutrition initiatives in the forefront. And then looking for CI opportunities. Right now we're looking at care plans. Down the road, once we have more standardization or similar numbers across the board for care plans and what we're doing in the inpatient, the discharge process is another one that we'll be tackling. But we want to make sure that we're in good form and good standardization on the inpatient side and our care plans first, and then we'll look to the next opportunity for the organization. On the next slide, always continue to move forward, where to go next, keeping that in mind, and that these numbers, this is a monthly report that we're getting now that will help us, see where we are on the numbers that we're receiving. So as we move forward, having your team informed, engaged, and involved is so important. As a manager, the frontline staff, they're the boots on the ground. They know what will work, what won't work, and can bring some ideas to you. But always keeping them also, motivated, providing learning opportunities for them that are more, that are inspirational. I think if people aren't doing the CEUs, and keeping themselves informed, they lose their excitement. So, offering those opportunities for lunch and learns and other things keeps them engaged and makes them feel a lot more valuable to the organization, which they are. So anyway, that's what I have for, kind of the overall getting things going and moving with MQii. It's been a great journey. And so, yeah, that's kind of where we are with things. And don't let delays frustrate you, because it'll get done. It's just sometimes the turnaround time takes a little bit longer.
Fabulous. Thanks so much. Yeah, thanks so much, Barbara. I think kind of helping the different individuals on the phone understand how to facilitate that relationship with their data folks, how to get to a place where they are collecting meaningful data that they can share internally, keeping, the teams that they're working with motivated and engaged are all critical. And I know at Intermountain, you guys did a really important process of looking at that data and using that to inform some of the quality improvement activities that you are undertaking. So hopefully, whether the individuals on the phone are officially working with us to collect those malnutrition quality measures or just kind of doing a more informal internal data collection and evaluation effort, this will be helpful as they think through where are those greatest opportunities for improvement and how they can communicate with their internal leadership or teams about how to use that data. So now we'll move on to our next speaker. We will have Louise Merriman and Kristen Matheson speaking to New York Presbyterian's ECQM journey. So Louise and Kristen.
Thanks so much. And Barbara, what a great presentation you gave. I wish we had heard it as we begin our ECQM journey, and I think we're going to give a little more granular information about our data and some of the MQii do's and some of the MQii don'ts, I guess. So I'm Louise Merriman. I'm the Administrative Director of Clinical Nutrition for New York Presbyterian Hospital, and I am joined here today with Kristen Matheson. Kristen, you want to introduce yourself?
Nutrition at New York Presbyterian Hospital.
Great. And today we're going to cover three basic areas. How we selected a site. We chose not to do every single site, and we'll tell you a little bit more about New York Presbyterian in a moment, what our performance improvement focus was, and then what our outcomes and what our ongoing focus looks like. We'll take the next slide. So we're a 7-site hospital system, about 2,600 beds, 2 large academic medical centers, a children's hospital, 3 community hospitals, and a psychiatric hospital. We've had a long-standing program for the early identification, documentation, and treatment of malnutrition, and we've had a history of doing staffing plans since about 2009 for patient-facing staff. I think we've added far more than 10 FTEs just based on our malnutrition initiatives. And in fact, Kristen, the position that Kristen is in came from one of our business plans about 6 or 7 years ago. That being said, as Barbara reiterated to us all, and I will reiterate, there are always opportunities for improvement. So as we took a look at what was going on at New York Presbyterian Hospital and our various sites, we wanted to make sure as we embarked on this that we had the focus and the bench strength. So we decided, and we'll take the next slide, to look at prevalence monitoring to determine which unit we wanted to focus on, and I'm going to turn it over to Kristen to describe that.
Thanks, Louise. So prevalence is a very important metric that we use every year to look at our internal data and then to benchmark against what the literature says, kind of like what our last speaker, Barbara, had mentioned, looking at the literature and what prevalence numbers are out there, and then also looking at other institutions to benchmark against each other. So prevalence is simply calculated by just dividing your malnutrition volumes into the total patient discharges at your institution. So for us, we like to use what's called adjusted discharges, and for this calculation, we back out certain patient populations like obstetrics, the NICU, and rehab, as those are patient populations that don't have clear-cut malnutrition criteria. So we back those patient populations out of the discharges so that we can get a prevalence that really makes sense for medical surgical types of patients at our institution. And like Louise mentioned, we have 7 campuses now with NYP, so that allows us to benchmark pretty nicely between our own campuses. So the centered 2 columns, CUMHB, is our Columbia campus, and then right next to it in red, WC, is our Cornell campus. Those are our two largest campuses that we have. They're somewhere between 700 and 800 beds each, and they treat highly acute care patients. As you can see, the prevalence for all of our other campuses are listed out on the slide, but we really thought, wow, that 5% gap in prevalence between those two sites that are pretty similar, we thought that was an area for us to focus on, and that's how we chose Cornell as our campus of choice for MQii. And as you can see, for 2018, we've planned for a higher prevalence target at Cornell, and a little bit later we'll talk about the outcomes from the Performance Improvement Project and how we're meeting and possibly exceeding that target for 2018.
Great, thanks, Kristen. Next slide. So this is our baseline data, and one of the mantras that you will hear throughout the next couple minutes of our presentation is that Angel is a very, very patient person. Also, as Barbara indicated, our coders are very, very literal, and we're still learning how to speak the same language. But if you take a look at our baseline data, clearly look like there's opportunity in the area of malnutrition screening. And then with our nutrition assessment, we were just shocked with that. Then when we really went back and looked at the details, we actually, our policy is based on days rather than hours from admission. And so when we teased it out to 48 hours, you see pretty respectable percentage. And then the 72, we think there might have been a couple of behavioral health patients in there. So again, pretty respectable. What we do see with our open chart reviews is that we've got very good compliance with completion and timeliness of our documentation. So you can see the nutrition care plan and the appropriate documentation of a malnutrition diagnosis pretty good. But we did know anecdotally and from speaking with our staff that the whole area of nutrition screening probably we could take a better look. So if you give us our next slide, the two areas that we decided to embark upon was, first of all, re-looking at body mass index as a trigger. So our basic screen that we do, nursing will ask some basic questions. They're kind of the gold standard: diminished intake over time, weight loss over time. We do use an admission diagnosis, skin integrity, and we use body mass index. And we had, for adults, been using just less than 19, but have been curious. We've seen that some hospitals have embarked upon use, for the elderly, using the body mass index less than 23, and wanted to see what impact that would have. And then speaking with our team, one of the things that came up is they said, gee, they would really like to know, for patients that are readmitted, were they previously admitted and diagnosed with malnutrition? And so we used a platform called Tableau to be able to pull that information. So we'll go to the next slide. And this is our implementation data. Actually, the screening didn't increase. It looks like it decreased. In terms of nutrition assessment, we teased it out a little bit further to comply with days from admission, and then you can see our care planning as well as malnutrition diagnosis doing pretty well there. And then our next slide, and this is post-implementation. Again, felt like the assessment pretty respectable, care planning and malnutrition diagnosis, but still issues with the screening. So we absolutely did learn that coders are very literal and that we have to learn their language. We also do know that we have to do a deeper dive with nursing and, make sure that the process that we have with them is more intact and we're having those discussions. But if we go to the next slide, and I'm going to turn it over to Kristen, we did see that it wasn't through the ECQMs, but we did see some pretty good outcomes. Kristen, do you want to describe that?
Yeah, so this slide shows in a graph format the malnutrition volumes for all of our campuses over a 5-year span, with the orange line in the middle being the Cornell data. That arrow indicates when we implemented our performance improvement projects. So that started around the middle of 2017, and as you can see, there's been a slow uptick in the trajectory of our malnutrition volume since then, even though there wasn't a large uptick in our screening data. We have seen an increase in volumes over time since then. So that's always a good story. Next slide.
Okay, so you might wonder, what does this have to do with our initiative? And it's just a reminder, I think it was about a month ago we started all hearing about the GLIM, and I just wanted to mention with this that we do use the Academy Aspen methodology, the characteristics. In fact, I was honored to be part of that group that worked to develop the consensus in 2012. This I found to be very interesting because they're using body mass index not as a screen as we do, but as a malnutrition characteristic. Next slide. So these are our goals going forward for us. It's really collaboration, collaboration, collaboration. You know, with the ECQM, we know it's electronic, but we also want to make sure that it's, you know, efficient and valid, so we know that we have to work with our colleagues in nursing more so. The whole training of our physicians has been an important part of our process. And we even look at training our medical students because we know at our institution about 30% of our medical students stay on to become house staff, and about 30% of our house staff stay on to become attending. Our work with information technology is ongoing, and right now we're working on the design of EPIC for EPIC rollout beginning across our sites in 2020, and that's pretty exciting. And then finally, we continue to work on our audit and appeals process. It's something that we've been monitoring since 2013, and just recently we've gone through 2 fairly large audits, external audits with Medicaid and Medicare, and that's been an incredible learning experience as well. So that's pretty much been our ECQM journey and where we see ourselves going in 2019. Thank you.
Thank you so much, Louise and Kristen. What an interesting story about kind of the process that you all have gone through, some of the different learnings that you've had, some of the recommendations that you're able to share, particularly as it relates to, as you see here, that collaboration component, and then seeing some of those outcomes that you've achieved. That's always inspiring and exciting to those who may be seeking to do this at their own facility and trying to figure out how best to roll that out and how best to implement it. I'm now going to turn it over to Lori and Cheryl at ThetaCare, and they're going to share with you a little bit about this ThetaCare nutrition risk screen and how that has supported identification of patients with malnutrition. So Lori and Cheryl. You guys may be muted. Give me 1 second to unmute you. Okay, go ahead.
Hi, everybody. My name is Lori Hartz, and I'm the manager of the Dietitians and Diabetes Educators at ThetaCare. Cheryl Shockey is our lead dietitian for all of our hospitals, and she is also on the call. We have 7 hospitals at ThetaCare, and we're in northeastern Wisconsin. So our our work really started very focused from a lean perspective about 10 years ago. And we really needed to identify the difference between a screen and assessment because there's so many nutrition risk screens, and there's also confusion about the assessment. So before the consensus statement, the subjective global assessment was kind of the gold standard, and it was used not only as a assessment, but it was also used as a screen. So we really set out to look at a screen as a process that identifies a patient at risk for malnutrition. Ideally, it should be very simple, reliable, and reproducible. And then the assessment, of course, is more of a complex process, and it requires a skilled clinician to obtain that diagnosis. So 2013, it's really exciting to hear, Louise, that you were part of that, and your improvement work is very impressive, Louise and Kristen, and I also really appreciated your data collection, Barbara. So when that 2013 publication came out from And and Aspen, for us that was really breakthrough, and that allowed us to really get to work on identifying malnutrition and doing improvement work around that. So we have an educator at ThedaCare. Her name is Angelica Gronke, and she developed a training and competency for all of our dietitians. It's fairly comprehensive. It's hands-on as well as a literature review and then competency application. And that really allowed us to standardize the practice for diagnosing malnutrition amongst our staff across our system. Because it was really so well done, our Wisconsin Academy of Nutrition and Dietetics requested that we offer this workshop to dietitians all over the state, which we did. So we were able to support many dietitians in Wisconsin on gaining the competency to diagnose malnutrition. So how did we really get started on developing this nutrition risk screen that we use at ThedaCare? So about 10 years ago, we started our journey into the lean methodology, which many hospitals do now. And when you start that, you start with a stat sheet huddle. So in the morning, every single day, the staff come together and we talk about safety issues, quality issues, defects in our work, how we support the patient care for the day, and celebrations. And the number one defect that was coming through was false positives nutrition risk screen. So we knew that we were seeing patients that really weren't at nutrition risk, and we also knew there were patients, the nutrition screen that we had in place was not catching. So while this was all going on, the dietitians, we had a secondary informal screen we were using in addition to the nursing nutrition risk screen. So we were informally looking at the patient's diagnosis, their BMI, their level of care, to determine if we really needed to see that patient, even though the nursing nutrition risk screen didn't catch it at the time. So how do we go about refining this nursing nutrition risk screen? It was honestly data collection is really the key, and diving deep into understanding why you're getting false positives. So all of the dietitians had data collection. It's called a daily tracking form, and then you have a Pareto form where you list out why the defect occurred. So the dietitians collected data both on when the patient was accurately identified at nutrition risk and when they were inaccurately identified. And then they would Pareto the reasons why truly they were identified accurately or not. So Cheryl Shockey, who is also on the call and will be available for questions, she worked on refining and defining the RD part of the screen. And so that really gave a lot of sturdiness to accurately identifying our patients with malnutrition. All of this information is found in the electronic medical record. We use Epic at ThedaCare. So within the first 8 hours, the nursing nutrition screen is completed. And within 24 hours or the next day, the RDs complete their part of the risk screen, and all of that data is in the EMR. Okay, so after we did this improvement work, we narrowed down the nursing nutrition risk screen to 3 questions. Unplanned weight loss greater than 7 pounds within the last 30 days, if the patient's eaten less than 50% of normal intake for 5 days, if they've received parenteral and enteral nutrition within the last 30 days. So if they answered yes to any of these 3 questions, we saw that patient within 24 hours. and that's 7 days a week. So this second part is the dietitian nutrition risk screen, and Cheryl put a lot of rigor into this to formalize it. So the first section, high-risk patients, and these patients are seen within 24 hours as well. Does the patient have any of the following? Are they intubated? Do they have failure to thrive? Do they have a PEG or J tube, short bowel syndrome, or malabsorption? Are they on a nutrition support order or a nutrition consult? Another part of the dietitian risk screen is Part B, and these patients can be seen in 24 to 48 hours. So these patients have a major GI surgery, they have liver disease, kidney failure, or renal replacement therapy, they have dysphagia, non-healing wounds, hip fracture, a stroke with an NPO diet order, PREED or thickened liquid diet order, some supplements, protein calorie supplements, or if they are a medical oncology admission. And also includes the renal diet or low protein diets or BMI less than 18.5. And then lastly, the last category on the dietitian screen is if they have any of the following criteria, the dietitian sees them within 48 to 72 hours. And in our nutrition navigator in EPIC, we do document the day they're admitted when that patient needs to be seen next. So if the patient came in with a small bowel obstruction and had no to all the nursing nutrition risk screens, and they didn't have a low BMI, et cetera, intubated, the dietitian would note that that patient would be seen between 48 and 72 hours. So this last category is moderate risk, and they may have a small bowel obstruction, pancreatitis, DKA, an amputation, inflammatory bowel disease, celiac disease, or dementia. So if patients did not meet any of these criteria, they were considered low risk, and the dietitian delegates that to our diet techs, and the diet techs screen them anywhere between 5 and 7 days. So because as we used the lean methodology and studied our screen because we really wanted to make sure we were identifying patients accurately, and we felt that we had this really sturdy platform to identify patients, we decided to compare our nutrition risk screen with the NRS 2002, which is the validated nutrition risk screen for the hospitals. I think it's interesting that so many organizations really use different nutrition risk screens because they are aware that not only is the NRS somewhat complicated to use, it misses a lot of patients, and that's what we found in our research study. So we enrolled in a clinical trial, and we used our 2 regional hospitals in Appleton and Neenah, Wisconsin, and we focused on all of the non-ICU patients. We had 564 patients. They were aged 63 plus or minus 16 years. So these were some of our results in the research study. We had a very high sensitivity, meaning 99% accurately we identified patients with malnutrition, and 64% for the NRS 2002. And that 64% actually has played out in other research studies. That's typically has been the sensitivity of identifying patients with malnutrition. The specificity, on the other hand, showed that we had more false positives in the NRS 2002, meaning we identified patients at nutrition risk that really weren't, more so than the NRS 2002. Okay, a little bit more data. So from the research study, we found that the positive on here are patients that were positive for malnutrition, either moderate or severe. We found a statistical significance with length of stay in the 30-day readmission. We also, and I don't have it on the screen, found a statistical significant outcome with mortality. So 36% of our patients that have malnutrition were deceased by the end of the research study. Another attribute of the nutrition risk screen, the ThedaCare nutrition risk screen that we developed, is it's very easy and quick to do. It takes 17 seconds to do the risk screen as opposed to the NRS 2002 takes 9 minutes to complete. So our current work, we are working with our providers. Our intention is we're doing a lot of data collection as well at each of our hospitals, and we compare the percent of the dietitians diagnosing malnutrition with the provider diagnosis. So we continue to work with our providers to educate them and assure that they are adding the diagnosis of malnutrition to our patients. We also identify patients with malnutrition outside of the hospital. So we're looking at using our screen in clinics before surgery. The whole goal of this is, of course, when we identify these patients, we can then intervene and we can help them improve their nutritional status. And at the other end of the spectrum, it also is a platform to have discussions about their quality of life and what their wishes are. So identifying patients accurately and early is key to quality of life. And lastly, we really want to focus on our collaboration on discharge planning to decrease readmissions. And through working with the MQii collaboration, I have some ideas, and I know Cheryl and I are excited to work on that with our team this next year. So that is it for my presentation. Cheryl, anything you want to add?
Just that we've been working really hard with the providers and the coders, and what we found that really helped the providers to actually document the malnutrition diagnosis, whether it's severe and moderate also, is we showed them information about how the documentation impacts the severity of illness. For example, if a person had a CVA and they were diagnosed with severe protein calorie malnutrition, their length of stay would be 4.4 days estimated, but if they don't have malnutrition, it's 2.2 days. So those numbers really seemed what convinced the providers, like, yeah, that really makes a big difference in looking at their quality scores.
Thank you so much, Lori and Cheryl. What an interesting presentation, and I think what a lot of our sites will hopefully be able to take away from that is not only understanding, how to do that, some of those quality improvement processes that you all went through, but also just thinking through how they can look for some of those signals when a screening process maybe isn't working, or, applying some of those learnings to other aspects of the malnutrition care process to see whether it's really working. If it's not working, why is it not working, and how can you improve those approaches? I also really love what you said at the end there, Cheryl, about, communicating and sharing that information with other providers or with your leadership, because that's such a critical part of making sure that others understand why you're doing what you're doing, the impact that it has on patients and their outcomes, and why they should be engaged and involved. As a quick reminder to our attendees, if you all have any questions for our speakers, please send them to us either via the chat function or the Q&A function, and I will be able to share those to our speakers. And the first question that we've received, actually, these two questions are a bit related, so I want to pose them to all of the speakers. Many of you spoke about both how to engage your IT or your data departments, and then separately, how to engage and work with other clinicians who may be less familiar with malnutrition or may not know why it's important for them to get involved. So perhaps you all could speak to, based on these questions, it looks like how to kind of find the right people and connect with them, and how to make it relevant to them.
This is Barbara. I think the one thing that I went over with my IT architect was the impact of the malnutrition diagnosis financially, and how this project will highlight by increasing, and you don't want it to be financial, but financial is important as well, but showing the difference between capturing that diagnosis of 1 in 3 people as opposed to not capturing that, and how it's spoken terms that way. And that really sparked me. It's like I had no idea, and I said it's really kind of low-hanging fruit of, in care. And on the flip side, yeah, we have this, but if we can capture this more, we can actually treat it more as well. So it has this double-ended, and that really resonated with him. He's like, wow, this is quite the project. And so that kind of motivated him to be like, yeah, let's start doing this. This is, so that's how we did. But then also to find the IT person, talking to other people working on projects and leadership positions, like, hey, are you building any dashboards? Are you collecting any information for things that you do? And that can lead you to the next person. So just being inquisitive with other leaders in your organization.
Thanks, Barbara. Did any of the other speakers have any other comments to add on to that, or should I move on to the next question?
I think Barbara did a really great job of that. Just maybe within the past month, we did a presentation for one of our nursing leadership councils, and it was shocking that, many of them didn't really know about disease-related malnutrition, although we've been working on this for a very long time. And I think it was very eye-opening for them to understand what it is. And then we reviewed some of the prevalence data with them, and I think that sparked a lot of conversation, but then also desire to understand more and what the impact is on patient outcomes, which we're all focused on. So that's
right, and I think that's something. Yeah, thank you. And I think that's something we hear from a lot of our Learning Collaborative participants, is that even though they've been talking about malnutrition for years, sometimes when they go to these different meetings or rounds or something like that, it's still, having to continually do that education and that communication. The next question we received is, it's what questions are asked for rescreening? I think this may be related to you, Lori, but it's about what questions are asked for rescreening.
We don't ask questions for rescreening. We just go and make the assessment, and we determine where they're at, and then we reassess them again based on what risk factors we found. So all patients are seen within 5 to 7 days, and they're continuously in our loop from that point on. So patients will get reassessed for malnutrition risk as well. So if a patient's been there, depending on what they were admitted for and how long they were there, the dietitian will also complete another nutrition-focused physical assessment or look at the criteria from the consensus, and they may become malnourished while they're hospitalized.
I'll mention we actually do have rescreening intervals, but we're constantly casting the net for, who may need our intervention, because daily we're looking at skin integrity, we're looking at diet order changes, obviously getting consults, et cetera. But just from recollection, I think our screen criteria most basically are, has the patient been, and we're monitoring for inadequate diet throughout that patient's episode of care. But has the patient had a weight change since they've been in the hospital, at the screen point, and then also what has their intake been like since they've been hospitalized?
Thank you. The next question is, do you have any tips for an organization that doesn't yet have access to data but is eager to get started?
You can manually collect data for all the patients the dietitians see. Just start collecting data on how many patients were identified with malnutrition versus risk or not malnourished. And then that may give you, a case to go further with your quality improvement work, comparing that to the literature.
I think that's a really good point. Kristen and I work with, we've been developing early identification, documentation, and treatment programs with our regional network hospitals, and we just over the past year or so set that up with 2 of them. And often what we'll start off with is is there any coding happening now, and what does it look like? And then, we'll start off by determining what is the prevalence now, what's happening, and then grow it from there. But that's kind of a most basic. In the past, we've had, and then we will look at what's the current incremental revenue, and then based on exactly what was just said, what's the potential prevalence, potentially what's the incremental revenue, and then do we, because we see this as a dietitian-driven program, do we need more RDs to achieve the best and safest care for the patient population? And we'll work on doing a staffing analysis along with it.
Oh, that's a great idea with the staffing analysis. So one of the pivotal things that helped me was we actually looked at our diagnosis rate and the literature, and we did a pilot, which at certain facilities we had I shouldn't say pilot, but we actively engaged the dietitians to speak with physicians directly if they felt somebody was malnourished and it wasn't identified. And then we compared that data with the year prior in that time frame and saw a significant increase with the active outreach from the dietitian. So it spoke volumes because it was, several $1,000s that we were able to increase that reimbursement rate related to malnutrition. And that was also our data architect actually pulled in, how it affected the rate, because sometimes it will help increase the reimbursement if it's an MCC. Sometimes it won't do anything, but they were actually able to compare how it affected the total reimbursement. So it was actually quite impactful.
Wow, great.
We identified that in our research study as well. And of the 150 patients that we had 50 patients that the physician and the RD matched. And just from that 50 patients from the coders, it was an additional $301,000 that we received in revenue. There was 50 of that 150 patients, it didn't make a difference. And then 50, the physician did not add the diagnosis. So we are aware that how much that made a difference for just 50 patients.
Great.
Thanks for that insight. And I would also add that I think this is very much in line with what we've heard in terms of success stories from some of the Learning Collaborative sites, is really to the extent that you can collect some of that data, whether it's for your own site, looking at the literature, looking at national expenses associated with malnutrition related to readmissions or related to length of stay or infection rates. Anything that you can share with your leadership and with other clinicians that is that evidence-based information has, I think, really helped many of our sites have an impact and try to get the people they need to be on board with implementing malnutrition quality improvement activity. The one last question that we received is, did you get any pushback from nursing when you were doing screening focused changes?
Initially we did, but the screen was actually easier, and they have several admission screens that they need to complete. And so that was included in it, and it was pretty easy. But we've had to continually work with them over the years to make sure it's completed. And actually, it's a question in our stat sheet huddle every morning to ask, was the nutrition risk screen complete? And there might be one or two across the system that it's not, but we follow up with them right away.
I'll say with the changes that we made, they really, because nursing was already doing heights and weights and the Tableau pulling up who was previously admitted and determined to be malnourished didn't impact them at all, so there really wasn't any pushback on that.
Thank you. Unfortunately, that's all the time we have for today. Thank you, everyone, for joining us for today's webinar, and I want to extend a special thanks to our 5 speakers for sharing with us the stories about what the work they were doing at their various facilities, how they've gotten to where they are today, some of the data and outcomes that they've been able to collect, and to answer some of the questions about how others can do this within their organizations. If you have any follow-up questions, please send them to me or send them to the Avalier or Academy team via the malnutritionquality@avalier.com email address, and we will try to pass them along to our speakers and see if they can get us a couple of answers and pass them back to you all.
Thank
we
you.
will also follow up with you via email after today's event to share a copy of the recording, a copy of today's slides, and the CPEU information. Thank you again for joining us today, and I hope you have a nice holiday season.
Thank you.